There's some simple basic concepts that I want to get across. Regardless of the experience level, perhaps the most common oversight is not having a system. And if you don't have a system, number one, you're going to miss things. Number two, which a lot of people don't realize, is you'll actually go faster because you're not going back and forth, and you'll be more accurate. Let's just get started with a particular rhythm. A 51-year-old man presented to the emergency department with palpitations that began an hour before he came to the emergency room. How would you interpret this tracing? Clinically, what would you do? And just think to yourself, how would you approach this? Again, 51 years old, palpitations. What do you think the rhythm is? What do you want to do first? And I always break this down by saying, well, we've got the rhythm on one hand, and we got the patient on the other hand. So if I showed you this rhythm, what's the first thing you want to do? What do you want to look at first? The rhythm or the patient? Obviously, the patient. And why is that important? Well, what if this patient is hemodynamically unstable? The reason that's important is because what if this is the rhythm and your patient is not hemodynamically stable? They're having chest pain with this rhythm, their blood pressure is low, they're mentally confused. What are you going to do? Does it matter at this point if this is ventricular tachycardia or a supraventricular tachycardia? And the answer is no, it doesn't matter, because if the patient is unstable because of this fast rhythm, whatever it is, you got to get them out of it as soon as you can. Now, having said this, how many of you thought that this was ventricular tachycardia? How many thought it was supraventricular tachycardia because the QRS isn't all that wide with aberrant conduction or something? And I would venture to say that neither of those answers is the best answer. Now, why do I say that? First of all, if this was ventricular tachycardia, do you have to shock the person right away? I mean, how long can you stay in ventricular tachycardia before you lose consciousness? Now, many of us kind of associate VTAC and the patient's going to become hypotensive and unconscious within seconds or a minute or so. But think to yourself, what is the longest in your medical career that you've ever seen a patient in ventricular tachycardia and stable, maybe aware that their heart rate's beating fast, but they have a normal blood pressure, they're talking to you, they're not having chest pain or shortness of breath? Do you think it's minutes? Many minutes? An hour? How about a couple of days? We had a case at a hospital just across the street from where my clinic was, where I was working, and basically 3 days. Everyone was around the patient, including several cardiologists that saw the patient, and they said, hey, you can't still be in ventricular tachycardia. It's 3 days and you're still stable. And in the literature, I kid you not, there's a patient who for weeks was in ventricular tachycardia. Now, the rate here is pretty fast, but if your rate is 150 and the patient otherwise has pretty good LV function, they may stay stable for a surprisingly long period of time. I'd like to know if it was ventricular tachycardia, VTAC, but I might not need to necessarily shock them immediately. I might treat them with some medication. So just to keep that in mind, the good news, even if it is VTAC, is that the patient, if they're stable, they may stable for a period of time. Getting back to the point that I raised a moment ago, neither of those is the best answer in my opinion. The reason is sometimes, many times, even the best rhythmologist or arrhythmologist cannot tell with 100% certainty what the rhythm is. Now, sometimes I know with 100% certainty, but a lot of times it's a probability statement. So the best approach to looking at this rhythm, and your colleagues who you're working with, if you're in charge of the code, is to talk out loud in terms of what you have. So, what is the system for talking out loud as to what the particular rhythm is? It's watch your P's, Q's, and the 3 R's. There are 5 parameters that you want to look at for every single rhythm. Once you've ensured that your patient is stable, you need to watch your P's and Q's and the 3 R's, and these are the 5 parameters. You want to look for P waves, or if you don't see any P waves, are there signs of atrial activity? Could be fibrillation waves or flutter waves. P's, Q's, is the QRS complex wide? And the 3 R's, which are what is the rate of the rhythm, the regularity, and whether if there are P waves, are they related to neighboring QRS complexes? Is the QRS wide? Now, what is wide? And a lot of people say wide is greater than 3 little boxes or 0.12 second. And I would submit that it's not necessarily even that wide. It's anything more than 0.10 second. Each large box takes 0.2 seconds or 1/5 of a second to record. Half of a large box is how much? It's 0.10. So a QRS, by my definition, is wide because all it has to be is more than half of a large box. And to tell this, I look for any QRS where the beginning or the end of the QRS either begins or ends on a heavy line. Here, this begins right on a heavy line. And is this more than half a large box? Yes, it's more than half a large box. Is a wide QRS complex. Doesn't look all that wide, but it is wide. Why can even ventricular tachycardia sometimes be wide with a QRS of just 0.11? Well, you can have what's known as a fascicular ventricular tachycardia. The hemifascicles, the anterior posterior hemidivisions, they're in the ventricles. You can have VTAC begin from them. And sometimes those QRS complexes are not necessarily all that wide. I want to emphasize key points about the system, and then we'll apply it to today's rhythm. It does not matter in what sequence you ask yourself the P's, Q's, 3 R's. And I often change the sequence. I use whatever is easiest to do at the time. So I often start with P waves, but not necessarily depending on it. Now, if I had a poll, I'd ask how many of you have ever used calipers? How many of you have seen your cardiologist use calipers? And those cardiologists that don't use calipers miss things. And I know because I've followed beyond them. If your patient is crashing, I don't say, hold up a moment, don't do anything, I got to pull out my calipers. If your patient is crashing, treat the patient. But if you've got a rhythm in front of you and your patient is stable and you have a moment at your earliest convenient moment, calipers instantly make you smarter. And they instantly tell you relationships that you won't know otherwise. And they end up saving time. I can use calipers and within seconds, I know what's going on. Okay, let's get back to today's rhythm. I said that better than VTAC or supraventricular with aberrant conduction or something would be to describe what you've got by using the P's, Q's, 3 R's. P's, P waves, are they present? Do you see them? I don't see any P waves here. Now, is it possible that there may be P waves in this particular rhythm? Hint. What percentage of a 12-lead ECG are we looking at? We're looking at one single lead. You can have part of the QRS complex that lies on the baseline. QRS may look narrow in one lead, but in reality, it's really wide. Or you could have P waves present in some leads and not present in other leads. So I don't see P waves here. The QRS we said was wide. Is this rhythm regular? We can look at this and say, yeah, this really looks pretty regular. We don't see any P waves. What is the rate? All of you, I'm sure, have different ways of figuring out the rate. I like to start with the QRS that begins or ends on a heavy line. Here, the point of this QRS begins on this heavy line here. And basically, each R to R interval is between 1 and 2 large boxes. Now, the problem when you have a rhythm that's this fast, if you're using the general rule most people go by is you take 300 divided by the number of boxes in the R to R interval. Well, we're between 1 and 2 large boxes, which gives us a rate between 150 and 300, and that's a big discrepancy. And for arrhythmias, accurate, quick estimation of heart rate can be very important. Atrial flutter. The atria usually go close to 300. So if I have a ventricular rate of 190, that's too fast for 2-to-1 flutter and too slow for 1-to-1 flutter. So I want to be able to quickly estimate accurately the heart rate. And I have what's known as an every other beat or every third beat method. Let's do the every other beat. How many large boxes does it take to record 2 QRS complexes? We have 1, we have 2, we are beginning on the heavy line, just a little bit over 1, 2, 3 large boxes. This is half of the rate. Half of the rate is a little bit slower than 300 by 3. So half of the rate is 90, 95. The actual rate is about 190. It really helps to know what we have is a regular wide tachycardia at about 190 per minute without clear sign of P waves in this one single lead that we're looking at. That's the best answer. Now, I come to this answer within seconds. So I've spent 15 minutes deriving it, but with practice, you can do this within seconds. What is your differential diagnosis? This is my differential diagnosis. This is one of my key lists of causes of a regular WCT, that's a wide complex tachycardia, when I don't see sinus P waves. There are 10 things on this list. What's number 1? VTAC. Number 2, VTAC. Numbers 3, 4, 5, 6, 7, and 8, VTAC, VTAC, VTAC. Now, why do I do this? Think about it. But the reason that I do this is because statistically, there's a literature to show if you had unselected patients presenting in a regular wide tachycardia without clear sign of sinus P waves, 8 out of 10 of them, before you even look at the ECG, are going to be in ventricular tachycardia. So it's always VT until proven otherwise. It could be supraventricular, and a lot of times people say if there's aberrant conduction, if the fast heart rate doesn't allow enough time for there to be recovery of conduction. But what if the QRS was wide to begin with? The patient had sinus rhythm with the bundle branch block. So this is cause number 9. And then cause number 10 is something else. Could have WPW rhythm. You could have hyperkalemia or some other toxic cardiac arrhythmia. So the best answer for today's tracing is here we got a patient with palpitations. We need to ensure that they are stable. If they're not, we're going to be cardioverting them immediately. And if they are stable, the good news is even if it's VTAC, how long might we have to think about what the rhythm is? You might have a couple seconds, couple minutes, you might have days. So I'm always ready to cardiovert with electricity at any point if the patient shows any sign of deterioration. But basically, I realize that I have a differential and it's VT till proven otherwise. So I said, before I even looked at the cardiogram, since it's a regular wide tachycardia, 80% is going to be VTAC. You could get up to 90% prediction if you just consider whether the patient is older, anybody beyond a certain age. I mean, 50 is young. Basically, it's of a certain age, 50s, 60s, 70s, not a patient in their 20s. And if the patient has underlying heart disease, then 90% of these rhythms are VTAC. I have an electrophysiologist that used to say this is a telephone diagnosis. Now, can I get beyond 90%? If your patient is stable, get a 12 lead. If they're unstable, we're cardioverting them, right? If they're stable, I like to know as certain as I can. But I like to get a 12 lead for two reasons. Reason number one, your patient's in a regular Y tachycardia, they're stable. At least half of the time, in my experience, by the time you get the 12 lead, your patient will be out of the rhythm and you look great. You didn't do anything. You got a 12 lead and they cardioverted. But the other reason is what to do with this patient long term will depend. Do you have to send them to the EP lab, to the EP cardiologist? You want to know what the rhythm is, and being able to see 12 leads will give you an important clue. A little earlier, I had asked, are there P waves? And you now have 12 looks, not just one. So we looked in lead 2, but I'm going to look at all of the other leads. Now, the second best lead 2 is the best lead to look for sinus P waves. The second best lead is V1 because where you place V1 on the chest is right over the atria. And then I like to look in leads 3, AVF, and AVR as other leads. And then I look at all 12 leads, and I don't see P waves anywhere. Those of you that have been experienced for a while with emergency medicine, regardless of your specialty training, are probably familiar with a whole bunch of rules. Some of these rules, if you're into cardiology literature, will talk about how long it takes to get to the lowest point or the highest point. And for me, with a crashing patient, I can't measure millimeters. So over the years, after looking at all of the literature, I've kind of evolved what I've developed, and I just call it the 3 simple rules. They're not perfect. They are my synthesis of what I see, because you can do these 3 rules fast. And in my experience, over the decades that I've done this, about 90% of the time, they'll really help. They're not 100%. Number 1, is there extreme axis deviation? If there is, it's probably VT. Now, what do I mean by extreme axis? I mean that if I look at lead 1, which is at 0 degrees, that's the horizontal lead, and lead AVF, which is vertically looking up from the foot at 90 degrees, if one or both of these leads is all negative, that's what I call an extreme axis. Number 2, look at the QRS morphology in lead V6. Now, if we think of where lead V6 is, it's a left-sided lead. It's over the apex, the left side of the heart. And if the rhythm is supraventricular, then there ought to be at least some activity coming toward left-sided lead V6. And if lead V6 is all negative, it's almost always VT. If lead V6 is a tiny R wave and it's pretty much negative, then it increases the chance of VT. It's not 100%. And the third one I love. How ugly is the QRS? Because with aberrant conduction, most of the time the QRS is going to kind of look like some known conduction defect, like left bundle branch block, like a right bundle branch block, or maybe a right bundle in one of the hemiblocks. And if it's a very ugly QRS, then it's less likely to be going down the conduction system, more likely to be starting from the ventricles. Now, this is not 100% because a patient could have started with a beautiful right bundle branch block and had a couple of infarctions and cardiomyopathy and got scarring. So with sinus rhythm, they may have a very ugly QRS. It's not 100%. It's nice if you can find an old ECG to compare. You won't always have this, particularly for patients crashing. But if you look at the QRS and it's very ugly, doesn't look like any known bundle branch block form, then it's more likely to be ventricular. Now, we're just doing probabilities. So what I said earlier was regular wide tachycardia. It is not. I mean, there's a tendency for people to say, hey, it's VT. Hey, it's an SVT with either a pre-existing bundle branch block or aberrant conduction. A better answer is the WCT, and I'm not quite sure. and I add a probability statement. Nothing is perfect here. I mean, we're rarely 100% sure of anything, except a few things we don't want to think about. So it's all a relative probability statement. And if your patient is of a certain age and has underlying heart disease, 90% before you look at morphology, it's VT. Now, I'd like to get as close to 100% as I can, but 90% is pretty good odds. Here's the 12 lead. How does the 12 lead help me? Now, think of those three rules I just talked about. One of them was axis. Is this an extreme axis? Rule number 2, what about lead V6? This is a left-sided lead. It's not all negative, but it's almost all negative. So I probably moved up a bit from my 90% to 93, 95%, somewhere in that range. If I knew this patient had severe heart disease, I'm over 95%. Is this an ugly QRS? Well, not really, because these are pretty straight lines. Lead V1 is a little bit ugly, but they're pretty much straight lines. So I do not know 100%, but I'm higher up than I was with 90%.